A round of applause, please, for the International House staff who put all the microphones and the lunch together. Thank you, International House. And I also really want to offer a heartfelt thanks for the groups that provided us financial and in-kind support, which included our sponsors, which you'll see on the back of the program on the last page on the bottom, including UCSF, Berkeley, Stanford, PNHP, a big amount of support from Business for Medicare-for-All, and also from California OneCare. So thank you for the financial support that made this possible. Our next speaker is a friend of mine from college, and he's not a health guy, he tells me. He's a law professor. He teaches corporate law, torts, what else?
Corporate finance.
Corporate finance. But along the way, this fellow had a really, really interesting idea about how to create parallel single-payer systems, which is, on reflection, I think not a contradiction, and he's going to explain. So Dan Greenwood, thank you for joining us.
Thank you for having me. Thank you for everybody else for all the things I've learned from you so far. So Jim asked me to talk about the expand your view from the insurance-centered view that we've heard Americans all have, and to talk about a somewhat different alternative, which I'm calling the VA for All option, or America's National Defense Health System. So here's the basic idea. Rather than simply having a Medicare for All system that is based on the existing Medicare model with fee-for-service or global budgets, that we should also have a system, in addition, that is closer to the National Health Service model, in which providers are directly employed by the government. So the notion would be we would have two systems: one, the system using a public payer but private providers, and one in which the providers are also public employees, much like the Veterans Administration, which I'm using as a model here, or just like we have public schools and private schools in the educational system. I am assuming that for risk selection reasons, we would not be able to allow people to be simultaneously in both systems. So the notion would be that you would choose on an annual basis or something like that to which system you wish to opt into. But it would be an option, not a requirement. There would be a choice of two fundamentally different ways of running the healthcare system. One in which the institution is basically government run, and one in which just the funding is, right? So partly the motivation here is that we already have these two systems. We have, on the one hand, the Medicare and Medicaid systems, which are a national insurer and private providers. On the other hand, we have the Veterans Administration and the remnants of public hospitals, which used to be quite important, or not so much anymore, in which government employees are actually the providers. The institution is a non-governmental or governmental agency that is run like a public agency. And generally, both in the United States and elsewhere, as you heard from the international experts, both the public provider systems and single insurer systems have been quite successful. You heard the NHS is enormously popular. So are the public insurer systems. The relative success, it seems to me, is likely to depend on details of implementation and politics. And so my suggestion here is that we open our thinking to the possibility that maybe we should get the best of both systems. Rather than choosing between one of them, on some arbitrary basis to pick them both. So what do I have in mind when I talk about a public employee service provider? Something in which the actual providers are paid salary like government bureaucrats, something that is open to everyone. So not like this is definitely not the existing VA, which is open only to the veterans. I'm using it as a model rather than as a formula, right? To the extent that we want to build on the existing institution, we've got the institution, it's the VA, but this would be a major change. Open to all, compulsory for none. A competitor to Medicare for all rather than a replacement. The one thing that it does seem to me we ought to learn from the VA is the importance of an independent funding stream, so I would think this should be on a separate budget. The VA is thought of as part of the general defense, although it's not actually in the defense budget. I would also think of this in the same way that we thought of the highway system as part of our national defense, and suggest that it be funded quite separately from Medicare for All, in part so that there is a different set of constituencies purely for political reasons. So why bother having duplication? First of all, in order to have comparison. Two systems mean we have two different ways of providing care. We can look to see which is doing a better job, and we will have automatic warnings if one of them is not doing what it should be doing. I would assume that if one system is remarkably better than the other, patients or providers or both will drift to the better one, and anybody who's paying attention will be able to see that there's a problem in the other one. Good faith administrators or legislators who are trying to improve the system will be able to learn best practices from two rather different systems, and maybe they'll learn more than if they're trapped within simply one. And conversely, when the politics are not so good, when a system is being neglected, the existence of the other one will make the neglect more visible, on the assumption that it would be difficult for a hostile administration to attack both at once. In addition, it seems to me that we ought to think and take seriously the difference between the ideals of a Medicare for All system and a Veterans Administration for All system. The incentives are quite different. So in a national medical system that is as actually a provider system rather than an insurer system, providers are working as a form of national service. Their primary incentives are less to make money, not to say that people don't want to make a living, of course they do. Government work is often perfectly good work, but you don't go into government work because you want to become a gazillionaire. You go to government work because you'd like a respectable living and to serve the public. And it seems to me that patriotism and national service are very different kinds of incentives than even the incentives that the most idealistic provider is invited to have. Not to suggest that they all do, but in a fee-for-service system, you're immediately driven to think about the pay. Professionalism and teamwork, constituency satisfaction are all more direct incentives in a government-based system than they are in a M4A Medicare for All sector that is based on capitation or fee-for-service. Often those kinds of team incentives work better. Often good enough for government work turns out to be a lot better than what happens in the private sector. I suppose that's the expertise I actually have here, since my primary focus is on corporate governance and its failures and successes. I spent a lot of time thinking about the problems in the private sector, and it makes me think having a public sector alternative is probably a pretty good thing. It's probably a pretty good thing. Bad as the a DMV often is, it's probably preferable to dealing with your local cable company. Certainly it's better than mine. That brings me to the third major motivation for having the dual system, and that's politics. We live in an era in which the DMV, despite the fact that in most parts of the country it actually functions pretty well and efficiently, is a joke line, right, for a bad job badly done. And it seems to me that having a highly visible, clearly governmental program that is likely to be highly popular is a reminder that government can do important things today and not just in the New Deal. We can still act like the richest country in the world and not just like, I don't know, I don't want to use the word that our president uses to describe unsuccessful companies, but countries. Similarly, it seems to me that if we can get some of the ideology of the defense budget, which seems to be immune to our periodic deficit hysteria, if we can think of this as part of defense as opposed to part of social services, maybe that will give a little bit of ideological protection to the funding sources. But even if that doesn't work, at least having two different systems means that in the bad era that seems to come around every once in a while, in the bad part of the cycle, there'll be two systems to attack. Successfully weakening one might lead to stronger defenses of the other. All right? So in summary, I basically am suggesting that a choice of systems, two quite different systems, both aimed at offering medical care for all, but using a different way to get there, a different route to get there, might keep them both on their toes. In particular, government and private sector service providers tend to have different problems, right? Different failures. All systems can fail, but they have characteristics ways of failing. The characteristic way for the government to fail is through stodginess and complacency, getting stuck in a rut. It's hard to move. The characteristic private sector failure is either excessive innovation for no purpose or grift, right? Or graft, depending on which way you like to say it, which is always a problem that we have as we privatize. And so I would say having the two systems means that we maybe get less of the two diseases and have can lean on the two strengths, which again are quite different, right? The decentralized market forces of the Medicare-for-All service and patriotism planning, limited options for people who hate choices, that would be me, right? Or those who lack the expertise to make intelligent choices about their medical care, that again would be me. I'd be perfectly happy to have somebody telling me, you have to go to this doctor, because that's what happens anyway, right? But it would be nice to have it in an organized system. All right, so that's really my all I have to say, except I did think that it might be useful to trigger the conversation by at least mentioning some of the obvious downsides. Two systems, it creates duplication and complexity that has to have some justification. There might be issues moving from one system to the other, of continuity of care. There may be competition, which generally I think would probably be a good idea, but it could also lead to one system trying to cannibalize the other rather than simply improve itself. And then there are the political issues. The political issues, partially in my terminology, by referring to the Veterans Administration, which I think is incredibly important in order to point out that this isn't some foreign import from the UK, those socialist strangers over in Europe. This is actually something that we've been doing successfully for a very long time. Inevitably, I get people who go, oh, but the VA is only for veterans, and they don't know about children, and they're very male-dominated, and that's a confusion of the terminology, but it actually has nothing to do with my proposal, which is really closer to a national health service than or it's to expand the VA into a national health service. So I think I'm going to stop there and take questions. So thank you. I would love it if you would have it. Okay.
Thank you, Dan.
I have a question.
So questions.
Yes, I have a question. I'm a family physician and 19 years in private practice, last 5 years with the VA. And one of the things, I am also a 7-year vet, honorable discharge, and not eligible for the VA. So I just want everyone to know that all veterans are not eligible to be seen at the VA, only if you're indigent or retired, military, or you have a service connection. So I would love, I think this is a great plan, to expand it for all veterans and potentially their family members as well. Certainly that was a directive for the Veterans Administration to start with. But one of the other things I'm always wondered, and I'm wondering if you can answer this question, how much does the VA get paid to care for people relative to how much Medicare Advantage plans get paid for those Medicare people?
So I have no idea, but I think that Suzanne might be able to answer the question.
Hi, sorry. My name's Suzanne Gordon, and I write about veterans healthcare and helped found something called the Veterans Healthcare Policy Institute. I don't know the exact amount of the difference between Medicare Advantage. There is in the attempt to privatize the VA now, there is a plan afoot funded by the Kochs to create Veterans Advantage plans. Yeah, so this is the next thing coming down the stream. But the VA delivers care because of what you mentioned, because not everybody's eligible. It's only the sickest, poorest, and indigent who are eligible, and they deliver care to the most difficult and complex patients for less costs than in the private sector. And all the studies show that VA care is equal or superior to the private sector. I just wanted to make a comment. Thank you for recognizing me. I'm not sure what I think about Dan's exact proposal because I haven't seen it before, but I think that in groups like this, we really need to think a lot about, because we're always looking to Europe and Canada, but we have a homegrown national health system in the United States. It should cover all veterans. It doesn't. Should cover their families. Doesn't. But everything I've listened to in the past couple of days, you know, we say we want more transparency, we want geriatrics, we want home visits, we want coordinated care, we want long-term care, we want reasonable pay for CEOs, we want reasonable pay for physicians, we want transparency, we want social determinants of health, et cetera, et cetera, et cetera. You got it in the VA. And the reason why they're demonizing the VA is the fundamental reason the Koch brothers have spent $52 million over the past 4 years to fund the Concerned Veterans for America is because they want to kill Medicare for All. They do not care about health care. They're not in the health care insurance business.
Suzanne, let me interrupt. This is extremely helpful, but I want to give other people a chance to ask questions.
Sorry.
So who's next? Who's got the microphone?
Hi, Mike Huntington from Corvallis, former mad as hell doctor, still mad as hell. And Oregon just completed a survey done by the Elway Institute on Seattle. And in keeping with what your proposal is, surprisingly, 75% of the respondents favored the idea of a universal healthcare system. 62% would pay 2 to 3 times their current state tax in order to be freed of premiums, deductibles, and surprise bills. And more pertinent to your comment is that they would accept a publicly operated system, not just a publicly insured system.
Okay, I think there was no question there. Up front here, do you have a question?
So my question is, I think bringing up the DMV is a great point. And one of the things we haven't talked about is the desire of people in upcoming generations to work for the government. And I think that that's something that was sort of brought up there. But what do we do to make it attractive for millennials, younger, people in Gen X to go into government to help with some of this that will need to be done and the bureaucracy piece when it's not very attractive right now?
I think the notion of serving the public is and always has been very attractive to a large number of people. When you spend a generation saying that people who work for the government are sucking on the public's teeth, right, and are not serving the public but exploiting the public, it gets harder to convince people that this is actually service. But that's part of the motivation here. It seems to me that we need to make government work respectable again. We need to say to people out loud, money is not our only value. We also value the community.
We have time for one more question before switching to the upcoming panel. So who has a microphone and wants to ask that question?
I'm Deborah Palmer. I'm a nurse practitioner, and I wanted to ask a question about doing the same thing with the National Medicare-for-All that the VA did, and that is removal of barriers to full scope of practice for nurse anesthetists and nurse practitioners within the VA. Do you think that would be something for the Medicare-for-All plan that you propose happening at the same time as a VA option?
Go ahead.
I think this is a question for somebody who's more in the weeds than me. So is there?
Okay, we'll give Suzanne another chance, and then we're going to, just a quick response, and then we're going to break and quickly go to the next panel. Suzanne. Can someone give her a microphone?
They've done that in the VA, and I think that also, I mean, it's something that people could consider in a Medicare for All plan. It would certainly get nurses, and nurse practitioners even more engaged in this discussion that they already do. And the VA, the VA's rules supersede state rules.
Well, thank you very much, Dan.
Thank you.
And Suzanne. My colleague, Doug Owens from Stanford, is going to introduce and moderate the next panel.
Welcome, everyone. I'm delighted to be able to moderate this. So the next panel is going to be Modeling Medicare for All, How Design Options Affect Predictions. And we have two experts in this, Bob Pollin and Jerry Friedman, both from the University of Massachusetts, Amherst. They have great expertise in this area, so we're really looking forward to what you all have to say. So,
great. Well, thank you so much, and thank the audience. I appreciate your willingness to tolerate my New York accent and my New York speaking speed, because I have what really should be 30 minutes, and I'm going to squeeze it into, starting now, into 10. Okay. So how do we pay for improved Medicare for All, and what's the, what are the modeling issues? It's actually pretty simple. And, there's been a lot of back and forth between right-wingers at Mercatus, liberals at the Urban Institute, which Bob will be talking more about. If you looked at Jim's article, he had like 25 different plans that were put out. There are a lot more than that. There's a company, the Lewin Group, that used to do modeling of state single-payer plans. Some of them were in Jim's study. Lewin, you may know, was bought up by United Healthcare. They closed it down. That tells you something about how virtually all people who have modeled improved Medicare for All have found reduced spending, which is kind of interesting because nobody has in any serious way counted some of the costs of the current system, like the extra burial costs for the people who die because of the current system, the lost productivity, or even the pain and suffering. Nobody has modeled the cost to individual householders of filing the goddamn paperwork needed to file your insurance claims. I mean, I could go on to the cost of marching down to the bank and depositing the checks if they ever get around to reimbursing you. But anyway, the standard practice is shown here. There are 11 basic variables. That sounds like a lot, but it's really not. Don't worry about it. Everybody, except I gather the Urban Institute, starts out with the CMS projection, Center for Medicare Services, projections for healthcare spending. So you all start out, except for the Urban Institute, start out there. And then you subtract the money that you're going to save. And we get into arguments about the size of all these variables. Insurance administration, that's the money wasted by United Healthcare, et cetera. Provider administration, that is all those people in those buildings where they process bills for the hospitals, or the people in the back of your office as a physician who are talking to the insurance company about, will you allow this, that, whatever. The extra price of monopoly drugs, and again, there are discussions, there's disagreement about how much they mark up drugs in the United States compared to what would be a fair price. And sometimes, people will say, well, I know they mark them up by all this, but you're not going to be able to get that money back. So we can argue about that. Monopoly pricing of medical devices and supplies. Monopoly pricing of hospitals. Now, you want to get somebody mad. I gave a talk a couple years ago. They invited me for some crazy reason. They invited me to address the meeting of the heads of research and teaching hospitals in Coconut Grove, Florida. What the rooms at this hotel were $985 a night. So I got up there and I talked about monopoly pricing at Partners hospitals in Massachusetts, the Harvard teaching hospitals. Afterwards, the head of Partners came up to me, really angry. We're not a monopoly. Right. So why do you get away charging 4 to 5 times as much as everybody else? Well, if we're going to price everybody at Medicare prices, some hospitals are going to take a huge hit. And that is a growing issue because, as you know, hospital prices have just been soaring relative to everything else. And then bending the cost curve by controlling inflation. Much of the inflation in healthcare in the United States, inflation rates that are higher than in other countries, 1.5% per year for 40 years, higher than in Canada. And some of that comes from rising administrative burdens, rising monopoly pricing for drugs, and recently, especially, rising monopoly prices at hospitals. So if you control those prices, you're going to be slowing the rate of inflation. And then what I call the magic asterisks, taking after the Reagan Office of Management and Budget, which put in magic asterisks. We're going to save all this money. That's not really fair because a lot of these savings could be real. It's just they're hard to measure. Greater efficiency from a single payer plan, reduced fraud, maybe greater savings because people will be healthier. And then you have to add, they're going to be expenses. First of all, you're going to be covering everybody in, nobody out. So people who now are getting very little health care because they don't have insurance are going to be getting more. Increased utilization. This is a big variable. Some people put it at 0, other people put it at 20%, because if you don't have copays or deductibles or you reduce those, you're going to be having more utilization of health care. Raising Medicaid prices to Medicare levels. And then another magic asterisk, transition expenses. How much is it going to cost? Here are my estimates. Now, if you looked at Jim's thing, I'm kind of on one extreme. My studies tend to be more optimistic about the savings you'll get. I estimate that 5% of spending over the next 10 years would be saved by reducing administration in insurance companies. That's $2.4 trillion. You can go down and see the rest. Provider administration, it all adds up to close to 30% will be saved, or 34% will be saved. The 10 years bending the cost curve, that starts out little, but it becomes bigger and bigger and bigger, obviously, over time. Extra costs, about 8% by my estimate, because of universal coverage, increased utilization, and raising Medicaid prices. Now, like I said, I'm more optimistic. Bob is a little less optimistic. You go to some of the people further over, but almost everybody, even McCaddis, finds savings. net of these greater costs. And these greater costs, they're not really costs. A lot of this is benefits. We've got to start working on the terminology here. Yeah, we're going to be spending more, but you're going to be getting something for it. I go out and I get a cookie. I pay for the cookie. That's not just cost. That's yummy. Yeah. Okay, how are we going to pay for it? I mean, look, there are some good, nice people who think we're just going to print the money. I'm not one of those. If you want to believe that, fine, go ahead, but not me. But you're not going to have to print all that much money. It sounds like a lot, but you're an economist in a big country. We're already going to be spending $28 trillion over 10 years on Medicare, federal Medicaid, tax subsidy of the private health insurance industry. That's like $2.5 trillion over 10 years. And then, a few little things like the VA and the Indian Health Service that we're not going to get rid of. We're just going to keep those as they are. There are other revenue sources that you could think about, but I'm not including them. Like, well, the federal government's going to be spending a lot of money on employee health insurance already. Maybe we should just put that into Medicare-for-All because those people are going to be covered that way. State Medicaid, that's $2.5 trillion. Well, actually, it's more like $3 trillion that states are going to be spending on Medicaid the next 10 years. Well, I'm not sure you can grab that back. Senator Warren thought you could. I'm not sure. They're charitable contributions that are a significant amount of money. Are they all going to go away if we have Medicare for All? I'm not sure. Nobody has counted those in. And then seniors are paying Medicare Part B premiums. I think we should stop that, but, yeah. So you take it all account by my estimates, which are optimistic on savings, but maybe a little pessimistic on actually how much money we already have in the system, and you're going to need $7 trillion over 10 years. Come on. That's one Iraq war or something, It's like, not that bad. Okay, I'm just putting some of these things here to give you orders of magnitude or suggest things you might think about. Taxable payroll, $69 trillion over 10 years. So if we just tax payroll, we need 10.5% payroll tax. Tax all adjusted gross income, which would include capital gains, interest, et cetera, profits. Hey, that's only 3%, not that bad. Put a consumption tax on. That's a great one because most people don't realize when they're paying it. A value-added tax, under 4%. Here's the change in net income. Whatever you do, if you do the most regressive form of plausible taxation, middle-income people will benefit. The poor won't because they're already not paying that much for health insurance. They will get better health care. And that's, again, we got to start thinking about the benefits as well as the costs. You know what they say about economists? They know the price of everything and the value of nothing. Middle-income people will be the biggest beneficiaries. Now, in these estimates, like Gabriel earlier, I'm assuming that all the money spent by employers on employee health insurance will become payroll. But that's not really necessarily right. But assuming that, middle-income people, working people, lower working people will get the biggest benefits. But you've got to go all the way out to like 400 grand before anybody will be paying more. And that's with the payroll tax. With the income tax, they do a little, they go even further out. So almost all Americans will save money under Medicare for All, not even counting all the benefits. If you don't want to spend all this, there are things you can do. Or if you want to make a better system, you could spend more money. You say, well, we're not going to be able to cut the hospitals that much. That's going to cost you more money. You're going to have a higher payroll tax. Pay physicians more on average. That's going to cost you a little more, a little higher payroll tax. Coverage options. Drop dental. I believe in dental care. I think teeth should be part of the body, and I certainly think glasses are. But if we drop those, okay, you're going to save a little bit of money. You can lower the tax rates a little bit. Cost sharing. I don't believe in cost sharing, but if you do put in cost sharing, of course, you could have lower taxes. What is this? You know, it's a shift from sick people to healthy people. I don't think that's a great idea, but, you know, that's just trying to give you a sense of the types of impacts you'll have. More cost sharing, you could really get the tax rate down. Okay, thank you very much.
Thanks, Jerry. Bob, I just ask that you avoid using economic jargon like yummy.
Thank you very much. Yeah, thanks, Jim, for inviting me. This has been continues to be an extraordinarily beneficial conversation that we're having here, and it's really thrilling to hear so many people out in the audience with so much to say. Just to speak to my own background on this, I'm entirely dependent on the real researchers that have been investigating various aspects of our healthcare system, where our expenses are, how we can bring down costs. I don't have any expertise in that at all. I was recruited into doing research on this by the California Nurses Association a few years ago, an outstanding group, and have been trying to pull together big aggregate stories building on the foundation of the work that a lot of people have done in this room, including our organizer, Jim Kahn, who, as I reminded him, was actually the very first true expert on researching healthcare that I met when I first started working on this. So Jerry, my colleague of 20 years at UMass, gave you a nice overview of the variables, and what I want to do is focus on comparing two studies. If you saw Jim Kahn's slide showing all the different results of the various studies, it's true that if you take the UMass people, it's kind of tilting in one direction, and then you have these other ones that were more, or they were more to the left on the slide, but actually more to the right in the world. So why? Is it just because, we have our predispositions are pushing us in that direction? I would argue, and my methodology in working on this stuff was actually always to take pretty conservative assumptions, not to push in terms of assuming that there's going to be cost savings beyond what the literature can bear, and for that matter, in terms of cost increases, like in particular utilization, assuming very high numbers, much higher than people like Himmelstein and Woolhandler would tell us is warranted. Even given that, you saw I end up with a estimate of costs that are dramatically different than what is now, I would say, the most widely cited study in the mainstream, which is the Urban Institute's study that came out a few months ago. So what I'm going to specifically do is compare what I and my co-authors came up with at Perry Political Economy Research Institute versus the Urban Institute. So as you can see, here's where we are. This is our conclusions. So we have our estimate for the year one of the program of Medicare for All. And my estimate is based on the 2017 Sanders bill. And there was a reference that we should really be working on the basis of the Jayapal bill. And I should tell you that I actually am doing some estimates on the Jayapal bill requested by Congresswoman Jayapal, and I just haven't finished. But anyway, I'll make reference as we go along to that. So my estimate with my co-authors was that in year one, we could deliver the 2017 version of a Sanders Medicare for All program at $2.93 trillion, which was a savings of about 10% relative to what the government CMS estimate would be under our existing system. We would save 10% and provide good quality care across the board. So we would have better care across the board, and we would be saving 10%. And that is the core of Medicare for All. So when we heard Jeff Sachs say, well, we've got to be able to deliver savings in order for this to be politically viable, I'm sure Jeff meant to say we've got to be able to deliver savings and deliver high-quality care, and that is what you can get under Medicare for All. If you believe more or less our estimates or my friend Jerry's estimates, that is not the case if you believe Urban Institute, and that's why this comparison is so critical. If you believe Urban Institute's estimate, Medicare for All does not achieve savings whatsoever. It increases costs quite significantly. And the fact that this has become kind of the standard reference has very powerful political implications. I'll just mention one. Senator Warren's proposal for Medicare for All takes as its baseline the Urban Institute study, and it works off of the Urban Institute study. Now, we can debate as to why Senator Warren's poll numbers have dropped ever since she introduced her Medicare for All program. But I would argue that that was not the best methodology for coming up with a cost estimate for Medicare for All. It boxed them in on the assumption that the Urban Institute estimates were kind of a good place to start. So our estimate was $2.93 trillion. Our Urban Institute's, and it wasn't based on Sanders, it was more like a generic Medicare for All program, but not all that different in terms of its coverage, was $4.22 trillion. So theirs is basically a 50% jump over ours. And if you remember the old Senator Everett Dirksen's line when he talks about government policy and budgeting, he says, well, $1 billion here, $1 billion there, what's the difference? Now we're saying $1 trillion here, $1 trillion there. Okay, so we've got a difference of $1.29 trillion in year one. Over a 10-year projection, Perry's estimate was $38 trillion, Urban's $56 trillion. $18 trillion difference. Trillion here, $1 trillion there. Okay, why? What are the sources of the difference? As it turns out, some of it is pure accounting. So that's actually more than 50% of the one-year estimate. That is, Perry starts with the year 2017 as our baseline, and Urban Institute starts with 2020. And between 2017 and 2020, the base actually goes up by $500 billion. So that's just a matter of pure accounting. Second matter of pure accounting is whether we're including in our budgeting for Medicare for All investment expenditure and public health expenditure. We excluded that because we were focused on health consumption expenditures. So when you account for that difference, that's another $260 billion. So roughly $750 billion is purely results of accounting. Then the other items where these are substantive. The treatment of long-term care. In the 2017 Sanders bill, there actually is no allocation for additional coverage for long-term care. I actually built in $40 billion of extra coverage just as a matter of principle, but the Urban Institute's estimate is $235 billion additional for covering long-term care, so that's a difference of $200 billion. Now here's another critical one, utilization, as I mentioned before. Our estimate was, we built into our study that it would be a 12% increase in utilization. And as Jerry referred to, we actually want utilization to go up, at least the opportunity. That's the whole point, that everyone has access to good quality care without cost sharing. So we would expect there to be some utilization. We can argue as to how much, but I deliberately built in a high-end number. My own estimate, based on our studies, was something like a 9% increase. I made it 12% because I combined my estimate in various population cohorts with Professor Thorpe, Kenneth Thorpe of Emory University. Wherever I had a high-end estimate, I put in my number. Wherever he had a high-end estimate, I put in his number. And that bloated it to 12%. Okay, so 12% is a very high number. Urban, actually, they don't have a number. And I debated the lead author, Linda Blumberg, last month on this. They refused to say what their number is. Weird. But anyway, we backed it out. So according to our methodology of what they should be telling us but didn't, their estimate is 16%. So their 16% number is really extremely high. It's higher than the Mercatus, the study sponsored by the Koch brothers, actually only has an 11.3% utilization increase. So that's $200 billion. Prescription drug cost reduction, we had a 40% cost reduction, which is a lower cost reduction relative to the OECD averages are paying 50 to 60% less for prescription drugs. Why can't we get to 50 to 60%? Well, maybe we can, but we only allowed for 40%. Urban says 23%. Why 23%? They just, they don't want to say 40%. They don't want to say 50%. They don't really give a lot of justification. That's another $100 billion. So here's where we are. The first two items, as I said, are purely administrative. That's $760 billion. The other three, $500 billion, that gets us to this difference of basically a $1.3 trillion difference between our study and theirs for year one. Now, what about over the 10-year horizon? Ours is 38, theirs is 56. The critical issue here, there's a difference in the base year, but the critical issue here is that we are assuming that once you establish Medicare for all, that we can stabilize healthcare costs as a share of GDP. Also a very conservative assumption, I would add. As Jeff Sachs was saying earlier, we're at 18% of GDP. The OECD average is at about 11% of GDP. If you do everything that's in our study, the US is still at 16% of GDP, 15.8% of GDP. So I'm saying we can stabilize at 15.8% of GDP, which I therefore think is a very conservative assumption, given where other OECD countries are. And the reason I think we can stabilize is because over time we can take into account the potential for gaining efficiencies. That is, reducing the physician-induced demand, reducing the degree of fraud, gaining over time the benefits of preventive care. The Urban Institute says that we are going to keep rising at 0.7% above growth in GDP. So there's standard estimates, which have become the ones that get referred to, New York Times, Paul Krugman, this is the respectable numbers. I think they're extraordinarily high. They're not justified in the literature, but there they are. And on top of that is one little coda. They say in their study, well, we don't actually use we don't use the standard data. We use our own accounting data, but if you went to the standard data, the CMS data, we would have to tack on another $500 billion. And like I say, I still haven't figured out what to do with it. The point is that this is an extremely important debate in that what hinges on it is, can we deliver a healthcare system that is able to achieve universal good quality coverage at lower costs? If you believe the Urban Institute, the answer is no. It's no. It's the wrong answer. Thank you.
All right, we've got 7 or 8 minutes for questions. Thank you both very much. If we could get the microphones, and again, please identify yourself, and let's try to keep it questions that are fairly brief so a number of people can get a chance to ask.
My question is, the focus seems to be on cost in the healthcare sector and taxes. You haven't addressed the economic dislocation of all of the people formerly, doing administrative work, et cetera, et cetera. So I'm just curious about how the job implications, unemployment, how all that factors into the overall economic impact.
Thank you very much for the question. There's different perspectives on that, and one of the curious things that's happened from our own study is the thing that's gotten cited the most in especially Fox News, is our estimate that there would be roughly 1.8 million jobs lost through the contraction of the private insurance industry and the administrative reductions, burdens that would result from transitioning. There's no other, when we say there's big cost savings from administration, the biggest way you get cost savings from administration is you don't need nearly as many people doing this work. So that would create dislocations. I think, is that what you were referring to? Yeah, that's real. And, I've been interviewed about this many, many times. They say, wait a minute. Are you one of those guys that's for Medicare for all? And if so, why are you making this point? Well, I'm making the point, number one, because it's true, and number two, because we therefore have to develop a just transition program, and the just transition program has to be central to any Medicare for all proposal. It can't just be a little side issue. Everyone who's for Medicare for all seriously has to also be for just transition. And how exactly you develop the just transition, we have some proposals in our study. They've been criticized as being too generous, as being not generous enough. I think they're not generous enough, personally, but it's something that we really need to work on. And the Jayapal bill does make reference to it in a very general way.
Yeah. If I can add a point to that, and Bob, of course, is one of the experts on this coming out of his work on the Green New Deal. Excuse me. But there's another aspect, which is that if we improve the efficiency of the U.S. healthcare system, we'll be taking a burden off of American business, which will then turn around and increase investment and increase the growth of the U.S. economy and lead to more employment. The money that's saved on people's healthcare expenditure will be plowed back into buying boats and buying vacations and doing useful things, maybe buying solar panels on their homes. And that's all going to create jobs. Plus, when people aren't locked into a job in order to keep their health insurance at a particular place of employment, they'll be able to start new businesses and be more productive citizens. And healthier people will also be more productive citizens. So all of this will create more employment. And I think it's reasonable to say that net employment effect of Medicare for All will be positive.
We have another question. And again, please identify yourself.
Mark Saper. Bob, I know there's an easy answer to this. I'm missing something, but you mentioned stabilizing the cost at 15.8%, but we've been using the current percent of GDP as 17.9%. What do I have wrong here?
My estimate, when I said the 2.93 trillion for year one of Medicare for all, that ends up being 15.8% of GDP. So again, I'm working on, what I tried to do was actually be very conservative and not be aggressive in what I think is realistic. So we ended up at 15.8% of GDP, and my methodology wasn't to say, how can I get to 15.8% of GDP? My methodology was to read like the true experts on specific aspects of the healthcare system, such as done by all the people in this room. And then it ended up at 2.93 trillion, and that ended up being 15.8% of GDP. And then I asked the question, well, how come it's still so high? Why can't we get it to 11 like Germany? We could, and if you heard Jeff was one of the readers on our study, and he and I argued a lot about this. He said, why can't you get it to 11? And I said, well, one of the big ways that we could get it to 11 is really to, cut incomes for providers. And I didn't want to take that one on. I'm not sure that's an issue that we want to take on. As he said, his own wife is a physician, but he was very firm. And if you want to, yes, you have to start cutting other areas of expenditure in order to get it much lower than where we are. And so the critical thing, I think, is, okay, we are at 15.8% of GDP. Let's stay there. Let's not, at least over time, not have the cost curve go up. And therefore, let's take advantage of these estimates that we, have 30% waste in the system. I didn't take out anything for that 30% waste. The assumption being that over time, we could gradually extract percentages of that, and therefore at least stabilize at 15 point. Probably we can do better.
I'm always so much on the extreme on these things that I'm delighted to be able to be more conservative than somebody. So I don't think we'll be able to stabilize as a share of GDP. I think we'll have a slowdown in the rate of growth, of course, but I project rising, slow increases. I use as my slowdown in the rate of growth just the difference between U.S. and Canadian price increases. So, I'm more conservative than Bob about that. It's so nice. I don't get to say that very often.
I think we've got time for one more question.
Hank Abrons from PNHP. Do you include any or forecast any changes in productivity of the U.S. workforce, and what is the scale of that? What would the impact of that be?
I don't think you do either.
I have it in qualitatively, in kind of at the end as a side point. I did not build in that as a significant feature. The productivity gain is obviously in the healthcare system, and that's very, very big. That is by getting rid of this massive administrative waste, and then also getting rid of physician-induced demand and improving preventive care. All of those are healthcare-related productivity gains. Well, I think we will get, as Jerry said, we have a healthier workforce. So people are going to show up at work more so that you don't have as much turnover. But I didn't try to model that.
I do have a graduate student working on it, but he's not that good, so I'm not sure it'll work out.
No comment. So we have one. You'll get the last.
I have a very
question.
short question. My name is Catherine Donahue. I'm a longtime registered nurse. I have a quick question. Who are the Urban Institute's funders?
I don't know. I know that they're considered, a major, slightly left of center in terms of Washington consensus politics. They're beautifully positioned there. They like staying there. I mean, I was on this debate with Blumberg, the lead author, who was a pretty nice person. She only screamed at me 2 or 3 times. But I would say they represent, I think it's fair to say kind of the Clinton wing of the Democratic Party. That's where they're coming from. We don't like them. Okay.
Okay.
You can look it up. I did, and I'm not going to say. At one point, I looked up the funders of all the major foundations funding research in healthcare, and it's a little predictable. But you've got to do that yourself. I'm not going to tell you.
I would just add that if you take somebody like Krugman, who is a major force in terms of shaping mainstream liberal opinion. As soon as the Urban Institute study came out, it was like, this is our Bible, this is the one we refer to, this is our reference. And as I said, even the Warren campaign took that as their baseline, which I think was a terrible mistake. Among other things, even if you read the Warren study, in the ways in which they use the they themselves are saying, we don't know where they got their utilization number from. They use it anyway, but what's the it? They don't know what it is because the Urban Institute doesn't it's not even transparent. You can't really work with it.
Well, I think we can all agree on the importance of modeling this, and so please join me in thanking Bob and Jerry.
Thank you.